Let's review nursing stages of labor. I'm trying to make it easy as much as possible, this topic. I'm going to do it in a very short, straightforward, precise form. You like to stick around. We'll start with some questions, then we go over it. First one. As usual, you get to read a question from the back and figure out what you're being asked, right? Which of the following the nurse should include? It's a select or apply. If you don't know it, just leave it. There may be only one answer there or two answers. Don't pick it if you don't know it so that you don't lose the point. And nurse is orienting a new graduate to the labor and delivery buzzword, right? The graduate want to know more about the cardinal buzzword movement during labor. Rewrite a question. What are the cardinal movement during labor? That's all. And then the best way to remember them, I just have an acronym. You don't have to even think about it. This is the one that I'll use acronym, like every day, find infant, enter, eager, and excited. Every day, find infant, enter, eager, and excited to come and see the rest of the world. And therefore, you're going to see I'm going to do that. So E is engagement. So that's good. D, the day, they will descend down. So they engage into the pelvic inlet. They have to descend. You got to go down. You can't come out without going up, by going up. But because of the narrow pelvics, they're going to flex their body to become smaller. Everything makes sense in science. So those are the fine guys trying to flex their body, right? And then if you flex, you have to internally rotate to make you smaller and smaller, not externally. After you flex, you internally rotate to make yourself small as much as possible. So that's the infant, internally. Then after you've done that, you pass the narrow portion of the pelvis. That's how they extend themselves now to show their head out. So they enter and they have to extend themselves. And then in order to present the normal presentation, they turn. So they extend and they rotate. And then they come out. Everything makes sense, right? They're engaged in a narrow pelvis. They got to go down, they descend, flex to make their body small, and they make it smaller by internally rotate. Then when they come out from the smaller area to the bigger area, they extend to show themselves, they externally rotate, and then they pop out like candy. Number 2. The next response will be what? She has to say something. And next is orienting a new graduate. The graduate want to know the most important indication of true labor. Look at it, the most important. So there's one answer, most. You have to know what true labor is. So what is the problem? Pain from the lower back to lower abdomen is part of true labor. Good. Pain does not result with walking. Part of true labor. Good. Pain leads to progressive cervical effacement and dilation. Part of true labor. Good. Pain increases with intensity. Part of true labor. Good. But guess what? Question test taking skills. The most. This is prioritization. Idea. You have to be sharp. The baby has to come out. If you have pain in your back to your lower abdomen, still, it does not tell me there is true labor. It's part of it. We indicate you being true labor. If your cervix is getting dilated and you face, oh God, the baby has to drop. So this is the most important aspect. So even though all these 4 are part of true labor, which I'm going to show you, the normal one is cervical effacement and dilation. That's how we know you got to pop the baby. So that's what we have to include that. Number 3. I'm using these as questions as a key fact you have to know. When should the nurse administer the medication? So time, right? A client is in active labor. That is where you give medication and you're requesting narcotic, okay? The physician prescribes butofanol. This is what you give them. It's a narcotic, like opioid kind of narcotic, right? When should the nurse administer it? The best time to administer medication to a pregnant lady in labor is when there's no blood going to the placenta. And when there is no blood, what time there is no blood? At the peak of contraction. When the contraction starts, the mommy start to contract the placenta. You have placenta insufficiency here. This is where the baby can have deceleration. You see, that's why we check whether they decelerating or they accelerating, or they have variable deceleration. Yeah, thus. So at the peak of contraction, there's no minimal blood flow to the baby. And so if you're giving the mother medication, yeah, this is the time I give you the narcotic so that it does not affect the baby. Okay, so not immediately, not at the end of contraction, is at the peak of contraction and not at the beginning. So this is 3. These are concepts I want to emphasize before we start the lecture. So let's begin. Thank you for sticking around. You should stick around more, right? Nursing stages of labor, right? So how do we start with this? First, key fact. Labor is the most important aspect after 9 months of pregnancy. This is the most important because there's death and life over there. A lot can go wrong. Okay, a lot can go wrong. And the key thing you have to know is when the doctors are thinking, they're thinking about the 5 P's of labor, right? Which is what? The passenger, whoever is coming, that's the baby, right? The passageway. How is the mommy pelvis? Is it small, narrow? Do we think we can deliver that baby? Do we have to do C-section? All these things they're thinking about. Can the mommy push? That's the power, right? And then what is the baby's position? Basic baby position, presentation and position is very important. So what is the position? You have to know that. And then you have to know the psyche of the mother. Is she ready to push? Is he ready to do this? Yeah. If none of this is favorable, we have a problem. So these are the things I want you to think about as you go through labor. That's why labor is very important. So when they ask you about the 5 P's, these are what they're talking about. These are facts. So I'm not going to waste too much. I'm giving you facts that you need for the test, not going to waste too much. So fetal position. There's difference between fetal position and presentation. So first, let me show you what presentation is. Presentation is how the baby is coming up, right? That they go into the pelvis. What are they presenting themselves? There's 3. There is cephalic, or they may be bridge. That's so. And then they can be shoulder. So these are the 3 presentation form. You want cephalic presentation. That is the best. So this is best. Then we're going to have a baby. That means they bring in their head. There is different kind of head presentation. It can be vectors. That's the best one. So this is the best. I want the head in the vectors position. But they can bring their face. I don't like that. Okay. They can bring their chin. I don't like that. They can bring their brow. I don't like that. Okay. There's another one called sit put. I don't like that. So these are the type of cephalic presentation, head coming by different portion of the head. The vectors is the right at the middle of the skull, basically, and you can feel the anterior and posterior fontanelle. This is how you can tell. So this is why we want cephalic presentation, okay? The position is different. Position is just in relations to the pelvis, basically. So position, it's a little bit different, right? It's the location, okay? It's the location of the fetal presentation, right? Part or presenting part in relation to the mother, okay? To the internal pelvis, basically. That's the easy way to say it. This is what sometimes confuses people. I will make it so easy for you. I want you to, like, you don't have to memorize this. This is the way I will draw the pelvis like that. I'm not good, but sometimes I draw. Okay, so if this is the pelvis, okay, this is the pelvic bone. This is the pubic area. So we call it, this is the pubic. The spine will be at the back like that. So these are all spine. So the where the pubic is located is anterior. and the spine is considered posterior. This is the mother facing me. If the mother is facing me like that, this is the mommy left side. And this is the mommy right side. It's opposite to you. So my right side is now the mommy left side. My left side is the mommy right side. It's the same thing when you examine patient, your right side is opposite. So when a mommy is laying down, having the baby, this is the left, this is the right. All you need to do is just to write. Remember that the best position when they come in, usually the baby will bring the back of their head. So everything is occipitus. So occiput. So I'll put left here. And here is the middle. This is the ischial spine. And so this is posterior, this is anterior, this is transverse. So I'll put transverse here like that, transverse. And the baby is going to bring their back. We're taking the normal situation. So the back of their head, occipitus. So this is the left side. And this is the left. The baby come to the left, left, and left, right? Of the mother. He brings the back of his head. So occipitus, occipitus, occipitus. Then if you bring his back of the head, which part of the pelvic is he touching? Is he touching the anterior? So if you bring his head and he touches the here like that, the anterior portion, yeah, that is left occiput anterior. If he touches the transverse portion, is that transverse. If he touches the back side of the mother, that using the back of his head, that is posterior. The same thing. If you go to the right side, the mother's right side, so I have right, baby use the back of his head, occipitus, and he touches what? The anterior aspect of the mother. The same thing. He using the right side and occipitus touching the transverse portion of the mother. And the same thing. Right side, occipitus, posterior. This is the way to make it easy. These are the presentation. So left occiput posterior. So when they write left occiput anterior, the way to read it, this is mother, the mother left side. This is the back of the kid head, occipitus, and which part of the mother they touching, anterior. The same thing. If I write this, I can say the baby is touching the right side of the mother, he's using the back of his head, and he touching the posterior aspect of the right side. And that's how you can remember, or you don't have to even memorize it. You can just draw it and say, oh, this is what it is. The best presentation is this, right, left occipitus and right occipitus. Right occipitus and left occipitus, anterior, front portion of it. So this is okay, we can deliver you. This is okay, we can deliver you. It does not cause the mother pain. The one that causes pain is posterior, right occipitus posterior or left occipitus posterior. And therefore, you have to know something about it. So we want right occipitus anterior or left occipitus anterior. Good. No pain with contraction. Okay. Right occipitus posterior, because it's touching the back of the mother's spine, or left occipital posterior. This mother will have back pain with contraction. So if they give you a question and they say mother is having labor, every time he has labor, he has back pain, what would you do? This is a classic question they will ask you. Number one, countermeasure or pressure. So when the mommy contracts, you put pressure on the back, on the spine or back as they contract, and this will help with the pain. That's key fact. Put pressure on the back to help it. This help with the pain. Then secondly, you got to help with the rotation of the baby. So you give them, sometimes I've seen it with birth ball. You see mother on the birth ball, and they are on their knees, and they're moving from front to back and forth, 30 minutes. And this will help with the rotation. It may help them move the baby from the back of the spine that is causing pain. I told you, every day, okay, guys, okay, infants, they just want to enter the world, okay? They are eager to do that, and then they're excited too. And so they need to engage the pelvis. You can't come out without engaging, right? Engagement. Then they need to come down, descend, come, let's go. Come on down, right? Then you got to make yourself smaller by flexing. Make yourself more smaller by doing internal rotation, okay? Then you got to make yourself bigger after you pass the smaller area, so extension, so that I can see you. And then more extension, also external rotation. Then I can pull you out, expulsion. And these are the cardinal movement. Now you need to know. Straightforward, right? Stages of labor, the back of the lecture now, right? Labor is very important. There's 4 stages, okay? There's 4 stages. We'll start one at a time. But before we do that, you got to know what is the true labor, because that's the question we ask versus a false labor. The way I do it is it's just straightforward. I use words, pain first. Then I go with the kind of contraction, right? And then I look for position, okay? Or let's go to the cervix. What happened to the cervix? Then position, your position or walking, changing position or walking, or anything can relieve the pain. And then I study one side, forget about the other side. So a true labor, we're doing true labor. True labor, this is what will happen. Pain, you start from your lower back to your lower abdomen. I don't even care about what happened to the false labor. This is what I know. Anything other than that, it's not true labor. That one can start from the lower back and go to your groin. That's false labor. But I want you to focus on the true labor, so that when they ask you a question, they will ask you what is the true labor. So why don't you learn something that will not confuse you? You just flip it back. That means any false labor did not start from the back and go to the lower abdomen. The contraction should be regular, right? And then it should have a rhythm, okay? It should have rhythm. Okay, so it's rhythmatic. So it has a rhythm consistently. And the key, okay, there should be effacement and dilation of the cervix. That means the cervix has to be thin, and the birth canal has to be longer, right? And wider, basically, dilation. If you start walking, your pain gets worse. If you change position, it gets worse. That means you are in true labor. Nothing can help with the pain. It's simple. And so I memorize this, or I know this. If they give me a SATA question, I'm looking for these 5 things. If I don't see it, I'm not picking it. That's all. There's a forced labor term that you have to know, this thing, Braxton Hicks phenomenon that you know. Like, this is irregular. Based on what I said, anything that is irregular is not true labor, right? Anything that goes away with walking is not true labor. Anything that does not change the cervix is not true labor. So that's the definition of Braxton Hicks. It is abnormal contraction. That is irregular. It goes away when you walk. Walking is the key. So when they say the patient walk and he get better, Braxton Hicks phenomenon, straightforward. That's the key aspect of that. That's the way you can remember it.. Okay, so this is going 1, 2, 3. Now let's go to the stages now. We have stage one. Stage one is divided into 3 phases. Okay, 3 phases. But what is stage one? Stage one is onset. So the time the cervix is 100% effaced. That's what is stage one, all 10 centimeter dilated. Those are the 3 things you have to do. When you finish stage one, you have to have effacement of the cervix and dilation to 10 centimeters, right? So that's the key. What is dilation? The vaginal canal become wider, and the effacement, the cervix become very thin, like a paper. Phase. The first phase one, is the latent phase. This is the early phase. This is usually, there's nothing going on. Is the most important thing is to encourage the mommy, teach them about labor. So you got to teach them about labor, what to expect. They may have apprehension. Their contraction is very mild, right? And then usually it's like slow. It takes a long time before they contract. So 5 to 30 minutes, that's the contraction apart. And then cervix is like 0 to 3 centimeters dilated. Probably 30% effaced, very small effacement. The key word is, you see, the contraction is going to be like, it does not last too long. So it's like 30 seconds contraction. So you can say they are very short. It takes a long time for you to happen again. Short, and then what is the right way? The contraction are very short, but frequency is long frequency. It takes a long time for another one to come. That tell you they are in phase one of stage one, right? It's like I told you, you have to encourage the mommy and everything to let them know. This is where they come in. We draw labs. We do labs. We do fetal heart monitoring, looking for deceleration, whether the baby can tolerate what is going to go on. Then, if you think they may need induction, this is the place you can calculate it. Okay, how would I know a patient will be successful with induction? We use something we call Bishop score. And the Bishop score is just looking at the cervix. It's just examination of the cervix. What is the consistency of the cervix? Okay. What is the position? Is it anterior, posterior? Some people cervix is behind. Okay. Some are below. So some are straightforward. How much is the mommy dilated? Okay. And then what is the effacement? This is what he's looking for. And the baby station. Okay, you want a station to descend as much as possible to like +1 to +2. Effacement, probably 80% effaced. That means they will do well. They can be dilated to like more than 5 centimeters is good. And the consistency is the position. The anterior cervix is very good. So anterior cervix. And then the cervix is very, very soft. Okay, that means they can tolerate, we'll be able to induce them safely with that. If none of these is met, this is the score. The score is from 0 to 14, and they grade them. The numbers I've given you a score of 3 for each, but you don't need to memorize the score. Just know what is involved: consistency, position, dilation, effacement, and station. And the keyword is Bishop score to look for whether the patient is going to be successful with induction. Okay, so that's phase one. Phase two is just basically, now we're getting hotter. We're harder. More contraction. You can think about it. It's more painful contraction. They becoming more frequent. Okay, frequent and longer. You're getting longer slowly, right? So usually you're looking for dilation to 4 to 7 centimeter dilated. they're going to like about 30 to 70% effaced. Effaced, that is what you're trying to achieve. In a contraction, like I said, they are stronger and then they are longer also. So like about 1 minute in duration. Okay, and they are 3 to 5 minutes apart. These are things you have to know, because when they ask you a question, this is what they put there. The baby, the water may break, water will break here. So you got to pay attention. If it does, check for the meconium and look at the color and look at it, whether it's stained with meconium. So that will means the baby have respiratory issue. So whenever the water break, you got to figure out what is the color, or ask the mommy, right? You may also teach the mother about breathing, because now, hopefully, when you taught them from the beginning, they know breathing technique, because they need it for the next stage of the labor, where they have to start pushing and they have to be able to. This is where you give them pain medication, so they can get like epidural or narcotic. Like I told you, you have to remember this narcotic, Postpartum. These two, and norbuphine. And these are giving peak of contraction, because that's where you have placenta insufficiency. This is where, that's why you give it to them. Okay. So that's phase 2. And then phase 3, now I call it phase 3 is the same as transition. We transition to stage 2. So phase 3 of stage 1, but it's a point where we transition to stage 2. So basically now contraction are like very, very stronger. And it's a little bit longer. The key word, okay, this is what you look for, tachy contraction. I will show you later on. You want duration of their contraction is like 90 seconds. Okay. And they are 1 to 2 centimeters and 2 minutes apart. So 90 seconds and 1 to 2 minutes apart. And the key word, 8 to 10 centimeter dilated and 100 centimeters effaced. You want to achieve that before you go to stage 2. That's very, very good. And the mother will show certain features. As soon as they get to this stage, they can ask you a sort of question. There's certain things you have to know. Now they feel like because the baby has descend, I show you there. Now the baby has descend, they're trying to do internal rotation, they're causing problem now. The edge and to have bar movement too. And then they have the edge to also push. And then I told you that, so the contraction is stronger. So you feel like, I got to push, I got to go. But you tell them not to do that until we're 100% sure the 110 centimeter dilated and effaced. That's key. You have to tell them. So if they are not, don't push. Even though you feel like you have the edge, don't push. They have to be 10 centimeter dilated if they're on the stage, phase 3 of that. They may be mad, okay, at this stage, insulting their husband, you know, because they say so many words they don't know, because now the pains, like if you screw up the nest, they may be mad at you. They will say something to you you don't like. And sometimes they may have GI symptoms, you know, like vomiting, you know, they feel nauseated. All these things are signs you have to know. If they ask you about phase 3, if I describe a patient is in labor and now have H2, have a bowel movement, H2 push, mad at everybody, trying to vomit, yeah, they are in like phase 3 of stage 1. Okay, so they should not push until they are like 10 centimeter dilated, you know. And then you see some mucus mixed with blood. This is blood show. It's no bleeding. That tell you they're ready to have the baby. We are in full mode. We can't go back anymore. So that means we are in full mode. So pay attention to that. So these are the things that happen. You have to know in the starter form: blood show, GI symptoms, mad at people, 10 centimeter dilated, and urge to poop. So this is the phase 3. And then we go to stage 2. We finish the stage 1. Now we go to stage 2. Stage 2, you see now they have the edge to go, have a bowel movement. The edge is even stronger edge to push. But you have to make sure what the stage is. The stage is 100% effaced. I've achieved it in the stage 1. And then you start from 100% effaced, 10 centimeter dilated to delivery of the baby. So this is delivery of baby. This is what the stage is about. So my main aim is to deliver somebody out. He's ready to pop out. So this is what we're going to focus on. Okay. Remember, they have like stronger edge. Everything is like so bad that it's very, very important. The duration of the contraction is like shorter. They're screaming at you, right? And they want to push. They also have a stronger edge to push, edge to have BM. It's the same thing like they were doing in the transition phase. It get bigger and bigger and bigger and bigger and bigger. But there's key thing that happen. There's a spontaneous need to push without them want to do that. So with contraction, without them not even thinking about it. As the contraction is coming, it will just force them to like push. Yeah. And this is what we call the Ferguson reflex. Yeah, that means they're ready to go. And then that time we know the 10 centimeter ready, so we tell them to push. How do you tell them to push? It's all breathing technique. It's nothing. It's just breathing technique. You make sure you prolong your inspiration and expiration. If you breathe too fast and breathe out fast, you get tired and you pass out, you CO2. So long inspiration, long expiration, slow, deep inspiration, and slow, deep, slowly expiration. You go through your nose, in through the nose, out through the mouth. And when you're pushing, I want you to open your mouth. That's all. That's what you tell them. I don't think there's anything with it, but these are techniques you have to tell them. If you are inducing them and they are on Pitocin, I want you to watch for this way. 90, there should be no more contraction. Your contraction should be less than 5 contractions in 10 minutes. The duration of the contraction should should be less than 90 seconds. That's maximum. And the frequency, okay, the time between contractions, you need at least 2 minutes. These numbers you have to know, because if they give you EKG, fetal heart monitoring information with the contraction, you have to be able to read it. So how do you know that? You got to look for the frequency, like I said. You got to look for the duration. Okay, you got to look for the amplitude. That's how strong it is. And then the tone. But 5 contractions in 10 minutes, you should not go more than that. The duration should not more than 90 seconds, and time between them at least 2 minutes. Those are facts you have to know, and in order to prevent tachysystole. Anything above that is considered tachysystole. We have a problem, okay? And then stage 3. What is stage 3? Placenta delivery, right? After the baby comes, it's just the placenta delivery. I think this is the most dangerous area. The placenta is if this is the uterus, it does not get embedded. So this is the uterus. The placenta will be here. It's just like kissing the uterus. That's all. And this is attached to the baby, right? It's just kissing it. It's not embedded into the wall. If it's embedded, it's called accreta. This usually needs C-section. It's just on top of it, so it can slide back and forth. That's why it move. It can move to the cervical horse, and it can lead to previa. This is why. So it does not basically implant completely. It just basically kisses in it. So it can come out easily. Sometimes you got to help with it. But helping inside can cause problem. It can break. Okay, you can destroy. You can have incomplete expulsion of the placenta as you pull it out. You have to help it as it comes. When that happens, they can have embolism. Okay, it can have embolism into the lungs. So anybody who is delivering a baby, all of a sudden, they have respiratory distress. It can be amniotic fluid emboli or from the placenta, and they can go into DIC. And you know what to expect: low platelet, low fibrinogen. They are PT, PTT, INR, or elevated. And what? They're bleeding from all IV lines. And you have to give them what? Supportive care, and give them fresh frozen plasma. You give them platelets, you give them RBC. You may need some heparin too sometimes, but this is the management. So you got to be careful. Okay, if you don't deliver the placenta well, they can have this complication. You can also have infection. So pay attention to that. And then the most important or immediate post-op is hemorrhage. If you don't deliver it, if you rupture, they may bleed. Okay, so they may have some bleeding. So pay attention to that kind of problem. And then stage 4, we deliver the placenta. This is 4 hours after the baby. And this is the time the mommy recover. It's just recovery mode, right? You want to encourage them to feed the baby by giving breastfeeding. Why? You release oxytocin. This will help the contraction of the uterus and prevent bleeding. The vitals is like usually Q15 times 4 the first hour, then Q30 times 2 the second hour, then Q4 hours. They may talk about fever if they ask you, okay? Temperature is usually 101.4. That's what we call fever. But this is not it's not a problem within 24 hours. After 24 hours, yeah, this is a problem. But if you give you a question, a temperature 100.4, don't worry about it. If it's within 12 hours, 24 hours, yeah, don't worry about it. If it's greater than 24 hours, yeah, that means we have a problem. That's bleeding. Okay? And you got to know how to count it. They may use words like saturated. Okay? You have to know how many times you're changing it. If I'm changing a pad every 5 minutes, that's not good, right? So you got to make sense out of it. Don't let them trap you. They will use so many words. Saturated. I'm changing it multiple times every hour. They're telling you that something is, they don't want to, they're giving you a clue that you should pay attention to that. Okay. And then finally, I just want to add this because sometimes they'll see it in the questions. These are key facts. Okay. You want the uterus to be what? Firm, contracted, small. These are words. Midline, as much as possible after they deliver the baby. If it's boggy, no, don't like it. If it's displaced somewhere, left, right, left, All right. Now, I want the firm uterus, contracted, small, and midline. Okay. If it doesn't happen, sometimes we give the medication, oxytocin, or we give the metal ganoven to help contract it. This will prevent bleeding. And this is what we use for postpartum hemorrhage. This is postpartum. It's a PPP hemorrhage. The same thing. You give it to them to do that, contract it. Remember, this medication, methyl-ganoven, you cannot give it to a patient who has hypertension or coronary artery disease, contraindication, because it's a vasoconstrictor. It will cause vasoconstriction and worsening. It give them stroke, heart attack. So you cannot use it. You should avoid it in these patients. Okay. Sometimes they will give you a question and then you have to think about it. Like somebody had a baby, the uterus is boggy, it's displaced to the right. So displacement sometimes mostly is because the bladder is full. So you can do catheterization and help with that. If they can pee, yeah, let them pee, okay? Let them urinate. If they have epidural, it's different. Epidural is because it loses the nerve innervation of the bladder temporarily. So this one, yeah, straight cut is a must, you know. If that, but if they don't have epidural, you can try to help them and pee. If not, you have to straight cut them. Otherwise, the uterus will become boggy, displaced, and cause more problem. Okay, over distended and get into trouble. Okay, so this is just few information I want to give you in terms of stages of labor and some of the highly tested information that you need to know. I hope you get something out of it. I'll make some questions. We'll do some questions later on. But take care of yourself. Keep charging. Subscribe for more information and check Adapt NCLEX for content to help you pass your NCLEX. Take care of yourself and keep charging as always. God bless you.